one of the most fascinating people I have ever met in my whole life. I am blessed with the opportunity to interview in just a few moments here on the Heart of Innovation on KDOW. You don't want to miss this interview. Here is this incredible entrepreneur who was inventing game-changing technology for treating asthma and is now tackling the toughest blockages in leg arteries that are, you know, put people at risk for amputation, ultimately a risk for heart attack and stroke. We're going to get into all this in just a moment. You don't want to miss this interview, so stay with us right here on the Heart of Innovation on KDOW.
AM 1220 KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Most innovators spend their careers solving one problem. Our guest today has spent his solving 3, maybe even more. From asthma to cardiovascular disease to peripheral artery disease, Sarvajna Dwivedi has repeatedly found himself at the intersection of major unmet medical needs. And today we're going to talk about that journey and the technology he believes could change how we treat some of the toughest leg artery blockages that physicians face. Welcome to the show, Sarvajna. We really appreciate you being here. He's with a company called AngioSafe, and we're going to get to that in just a few minutes. I know so many people that are tuning in right now have what's called peripheral artery disease. It's those blocked leg arteries. It's a disease more prevalent and deadlier than most cancers combined, yet 70% of Americans don't know it exists. And so many primary care doctors don't even know it exists, with regular textbook symptoms of leg pain and leg cramps and neuropathy being brushed off as diabetic neuropathy or neuropathy caused by back issues. Or I've even had some patients come to me with a hip replacement who didn't have any sort of pain relief until they got their arteries checked and arteries revascularized. So we're trying to spread the word here. And one of the biggest Achilles heels for doctors, it's long calcified blockages in the legs. And that's what Sarvajna is doing. That's what he's tackling now. But we're going to get to that in just a bit, I promise you. But first, again, Sarvajna, thank you so much for all you do. Thank you for being here to share your story.
Thank you for the invitation, and thank you for what you do for patients and the disease. I look forward to the conversation.
And everyone might be noticing that Dr. John is not here today. His son actually made the finals, I think, in his one of his sports that he's playing. So Dr. John is out there at the stadium right now, but we could say hello to him. I'm sure he's tuning in, but we're going to honor him with his regular moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
Okay, Sarvajna, here we go. So I was really thinking about what quote I wanted to use. And because I just look at you as maybe the Steve Jobs of medical, I had a quote, I think, that he said, it's often attributed to him. People who are crazy enough to think they can change the world are the ones that do. And you've gone from respiratory medicine to cardiovascular disease and now peripheral artery disease, really repeatedly stepping into spaces where the challenges are significant and the stakes are high. Do you think you are crazy enough to think that you can change the world, aren't you?
Steve is an inspiration to many on planet Earth, and he is one of my sources of inspiration as well. Rare few will rise to the level of his stature. So thank you for that comparison. Crazy enough, is perhaps one way of characterizing my journey. But more importantly, it's focus. Focus on one thing and only one thing, solving clinical challenges, wherever they might be.
And for you, a lot of the challenges that you have tackled, at least in the latter half of your career currently, it's really come from what I would consider life experiences. And that's with cardiovascular and vascular. We'll get into that in a moment, especially your dad's story that I want to make sure that we do share, because that was your foray really into the cardiovascular world. But what ultimately got you started in the world of asthma? And this is what triggered, because I have asthma and I use the inhaler you helped to invent.
Yes, inhalation is absolutely key to life.
Yeah, we need our oxygen.
Nearly 5 to 600 million patients worldwide suffer from partial or total obstruction or chronic obstruction, episodic or chronic obstruction of airways and breathing. So breathing impairment requires us, the scientists, to deliver medicines to the airways consistently, as diligently as the damaging aerosols deliver damage to the airways.
Yeah.
And that has been my focus since 1992, when I first got involved in industrial pharmacy work after finishing my PhD in Canada. Where I had done my PhD work was strictly in making tablets, how to keep particles together, and understanding the mechanics of what keeps certain types of powders together when other powders fall apart, even after high speed and high pressure compression. So Glaxo called me, the world's largest company at that time, and said they were establishing an inhalation products development division, and they wanted me to come work for them. And I was the one questioning them, hey, I know how to make tablets. Are you
I was
sure
just
you
going to
want?
say,
Right.
well, wait a minute. How did they put two and two together and think that you were the man for this job?
This is how. So when I posed that question to the hiring manager at Glaxo, Dr. Paul Atkins, another British scientist, a brilliant scientist, uh, he said, look, you know how to keep particles together. Therefore, you can figure out how to keep them apart too. Just join us. That was his logic. The forces that are keeping particles together, you just need to work in the opposite direction, and you can make inhalers. That ingeniousness is the one that gave me the confidence to jump over onto the inhalation side. And in a matter of months, I became involved in solving the challenge of making Ventolin, the world's most prescribed inhaler, that had serious challenges at that point in time in transitioning from the old propellants in the spray inhaler to the less ozone depleting propellants. That was 92, 93 timeframe. And one of the key inventions that led to Ventolin came from where my experiences were. So I'm very, very proud of that work. And then later on, 2 drug inhalers, 3 drug inhalers, a 29-year-old journey.
This is incredible for everyone watching right now. Here is someone that has touched almost every person's life with his invention. And coming up next, right here on the Heart of Innovation, how does someone go from developing asthma technology, breakthrough asthma technology, to tackling some of the most difficult artery blockages in medicine? Well, we're going to find out when the Heart of Innovation continues on KDOW. Don't go away. Wow. This is just incredible. You are amazing. And I want to get into, I think I'm going to start out, Sarvajna, with, and I'm curious if you can relate to it, because we'll sometimes we recap a little bit of what you said from the last segment into this one, just in case people are joining in on the radio. But Sir Richard Branson, when he asked me to run his global startup competition, and I'd never done that before, what he said was, don't let what you don't know and have never done before get in the way of doing something great. Sometimes it's what you don't know that could lead to the greatest breakthrough. And I see you nodding. So I kind of think that it's the same with you. It's what he meant was everything you've done in your career is literally going to help you think outside the box and to be able to solve this other problem. Like, I like this aspect and this aspect and this aspect of what you've done. No, you haven't run a startup competition. No, you haven't broken particles, worked on the opposite, right? With separating the particles, keeping them apart. But you have that mind to be able to think through it. And if there was someone that was working in that space, well, if they would have solved that problem, they would have done it already.
30 seconds.
Right? So I thought that that might be a great way to start out and have you comment.
Sure.
Oh, hold on one sec. Here we go. Oh, good. We have a long segment here. You can talk as much as you want in this one.
877-579-8630. That's 877-579-8630. AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hey everyone, welcome back to the show. Dr. John Phillips is off at his son's lacrosse game. They're in some sort of championship mode, so he is there cheering them on, but we are here holding down the fort. We have Sarvajna Dwivedi. He is the CEO of AngioSafe, and before the break, we were talking about the start of his journey in inventing breakthrough devices. We were talking about the inhaler, and at the time, when he was recruited to invent what we consider the new form of inhalers for asthma, he was actually spending most of his time with tablets and helping to figure out how to keep the molecules together. But now they want him to, at Glaxo, they want him to keep them separate. And that really reminded me, Sarvajna, of when I was asked, I was a journalist by trade, I was asked by Sir Richard Branson's team to run his new global startup competition. And I was like, I don't have any experience doing that. And he said, don't let what you don't know and have never done before get in the way of doing something great. Sometimes it's what you don't know that could create the greatest breakthrough in any industry. And I think that that is what happened with you.
Indeed. First of all, solving challenges in my profession, solving clinical challenges requires us to understand the disease first. You can never work technology forward and identify a solution. You have to work disease backwards. Exactly what's the need of the disease. Second is work with nature. Nature is the best inventor. My firm belief is that all of the patents on the planet Earth, they are simply already a part of the nature. We just discover them and we call them our discoveries when they have already been around. And I'll give you an example of how that came about in one of my inventions. So you were talking about entrepreneurism, startup competition, and so on and so forth. To solve the challenge of combining multiple medicines and delivering them to the lungs as if they are being delivered from separate inhalers. That's the need. When patients start to use separate inhalers, the scientists tend to put those multiple drugs into one inhaler for the sake of convenience. Convenience isn't the goal. Better clinical outcomes are the goals. So, and to do so, one still has to deliver those multiple drugs from one inhaler as if they are being delivered from separate inhalers. And that could be done with a low density particle technology that I wanted to use to develop certain inhaler types, which my management wasn't supporting when I was at a certain company. So I chose to license those technologies out with a colleague of mine, and the two of us joined hands to launch a company called Pearl Therapeutics. It took us 3 years to get the license, but it took us 12 weeks to raise the first $22.5 million because science was strong. And that's how I became an entrepreneur, thinking that the technologies we were licensing were mature and they would give us the answer to those challenges of combining multiple medicines. Turns out they were not mature enough. And we ran into some serious obstacles that we had to overcome. And one of the discoveries we made, the nature has already discovered, dandelions. The seed doesn't fly, but with the little umbrella, the seed and the umbrella architecture becomes low density architecture. And then it covers the meadows with beautiful uniform coverage of flowers, dandelion flowers. We discovered dandelion-like particles in our inhalers, serendipitously, true discovery. In 2008, a month before the collapse of Lehman Brothers, where the high-density drug crystals and low-density phospholipid particles, the two of them attached, they started to float inside the inhaler, and now we could deliver drugs to the lungs as if smoke delivers damage throughout the airways. That's the discovery that led to multiple combinations, lot more capital raise despite the global collapse of the economy after 2008. And now that journey has led to three major products that are already helping patients in day-to-day clinical practice through AstraZeneca. Because AstraZeneca acquired that company, the VCs made $1 billion by selling us to AstraZeneca. And now there are three products. One product called Breztri, a triple combination. Another product called Air Supra. And the third product called Bevespi. Two drug combinations, one 3-drug combination. Each one of them delivers drugs to the lungs as if those individual drugs are being delivered from their separate inhalers. For the first time in 60 years of those inhalers, we could do so. So discovery is a consequence of pursuing a clinical challenge while being respectful to nature. That's one journey.
How in the world, dandelions, this all stemmed from dandelions?
This all was explained by dandelions. When we discovered, we didn't even realize we actually had discovered dandelions. So as Dr. Phillips is away at his son's lacrosse game, I used to be at my son's golf tournaments. He was a rising junior golfer. He became a Division I golfer for Duke University. He played men's D1 golf. Walking the golf courses, this was in Santa Barbara. I was walking a golf course with him, and I saw these dandelions. 5 years after the discovery of these low-density, high-density particle constructs, I saw these dandelions and I said, hey, this is what we have done in our inhalers. So it's not easy to come up with discovery, but when it comes up, recognize that you've been blessed with a real chance by the nature to do something really unique for your challenge. And in my case, it happened to be asthma, COPD, chronically obstructed airways. And that's what I'm grateful for, that we discovered something because we were very, very sincere to the clinical challenge. And then I got introduced to the other challenge, which is one of vascular obstruction. So you referred earlier on to transitioning from asthma to blood flow obstruction. Ultimately, both of these areas deal with the same challenge.
It's obstruction, right? You have airflow obstruction, you have blood flow obstruction.
Absolutely. Lack of supply of oxygen to the target organ. For asthma and COPD, it happens to be the total body. For obstructions in blood flows, it happens to be a region of the body. But it's the same profession, supplying oxygen and nutrition. And that challenge is the second one I've been tackling by formation of AngioSafe.
It does. So I hadn't thought about this before. So there is that similar. You're trying to break up the particles, right? You're trying to separate them versus in the beginning, you were trying to put the pieces together.
Yes. So this is very, very interesting challenge here, the blood flow obstruction. The blood vessels get the cholesterol deposited in their inner layers, and that layer grows with time. Just nature. Macrophages get involved. They eat up the cholesterol. They become foam cells that starts to narrow the blood vessel. And eventually the narrowing becomes more and more and more severe when patients begin to see symptoms. And ultimately, the stenosis, narrowing, becomes occlusion. And if the occlusion lasts more than 3 months, then it's called chronic total occlusion. So I was introduced to this challenge again serendipitously through my father's heart. So while I was at the peak of building my last company, Pearl Therapeutics, we were doing some massive amount of work, large clinical studies for COPD patients. I received a call that my 80-year-old father had a heart attack.
And coming up next right here on the Heart of Innovation, we're going to find out next and what Sarvajna was able to create to help other people that were suffering like his father. So stay with us right here on the Heart of Innovation. Don't go away. He says, good dive. Yeah. Whew. I was jumping right in. I was trying to find that perfect moment to get there so we could go into the heart. But holy geez, how is this? Did I just miss the story that was out there about all of this? Because I've been in technology for a very long time, medical technology for the last 10 years, and I have never heard this story.
I just tend to let my products speak. Let the clinical value be the best spokesperson of my work. Where I come from, very humble background. So we tend to be at the back of the room and let the speaker from the podium do the work. And in my case, those are the products.
Yeah, this is just amazing. I don't, have you told this story like this to the media before? I need to go look it up.
Not to media, but there was an event in Silicon Valley when Pearl was sold to AstraZeneca. There was $1 billion exit. So all of a sudden they found that somebody built a pharma unicorn in Silicon Valley. So they asked me to come tell my story. And that is my story event that is on YouTube somewhere. They recorded it, they posted it on YouTube. They didn't even ask me. So that story is there on YouTube from 2014 onwards.
I think this is the story that Silicon Valley completely missed.
Yeah.
Oops. Because this is one of the most inspiring stories I have ever heard. And with so many people affected, especially whether it's allergies or asthma, I think most people have been on one of your inhalers at one point in their life or another.
So it's remarkable. I was in Istanbul at a conference with doctors. And a Pakistani physician walked up to me and said, hey, I'm using your inventions to treat the royal families in Middle East.
Wow.
So my work reaches places where I physically can't reach, and I'm helping those bodies at a very pharmacological level. So that's the impact of my profession. I don't really need to speak much.
No, and in fact, you couldn't speak all week, so I'm glad your voice sounds amazing. You got your voice back.
Well, thank you.
For those that are listening in, he had laryngitis this week, and we were very lucky, and I'm so thankful that you
30 seconds.
Are here. Thanks, Christy.
Protect your family today. Call the Term Lifeline right now for a free quote. 866-558-TERM, 866-558-TERM, 866-558-TERM.
Here we go.
1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hey everyone, welcome back to the show. We have Sarvajna Dwivedi. He is the CEO of AngioSafe. AngioSafe has invented a really cool device that can burrow through the tufts of calcium in the leg artery blockages. And I promise you, we're going to get to that in just a few moments. But for those just tuning in, I mean, Sarvajna has gone from creating a breakthrough in treating asthma, and now he's getting ready. And before the break, we were just leading into his cardiovascular breakthrough. He had heard that his dad had a heart attack. Sarvajna, what happened when you got the call? What was that call about your father?
So he was 80 years old at that time. This is 2011, May timeframe. I was about to caddy for my son at US Junior Amateur qualifying event. Oh, wow. And I received a call that my father had a heart attack. He survived that heart attack because that happened 100 meters away from the home of a retired cardiologist who had a five-bed acute care unit at his home.
Oh, no way.
And then we took him to a major institution for cardiovascular interventions and surgeries. There, they discovered that he had 3-vessel disease. His left anterior descending artery, his right coronary artery, both of those were totally occluded. And the third, the circumflex artery that goes behind the left side of the heart, was 90% occluded. So the physicians told me that his heart was failing. He was surviving on nature's bypass, the collateral arteries. And there are about 50% of patients who have collaterals form, the others don't. Because this is just how the nature works. The vascular endothelial growth factor release does not occur in everyone, so collaterals don't get formed in everyone. So he was in the lucky 50% group. Now, heart failure, 2 vessels totally blocked, 90%. They found the path through the 10% opening in the third artery, opened it up, put a single stent, left the 2 totally blocked arteries alone, and sent him home with medical prescription and a stopwatch in my hand telling me he had a chance of surviving in 5 years of 20%. So
that's not easy to hear.
And he was a literary giant. He has produced more literature, 6 times more poetry than Shakespeare. In Sanskrit, Shakespeare wrote in English. So all of a sudden, there is this dead end. And I was working on my company on the asthma and COPD side, for therapeutics. So I started to read interventional cardiology. Why is it that those physicians in the 21st century with modern material science and mechanical engineering, they felt uncomfortable trying to find a path through those total blockages? Because after all, it's a tissue that's stuck inside a blood vessel. No matter how it happened, and no matter how risky the location of the blood vessel is, it's a mechanical challenge. And I realized that the physicians were and still are dealing with inadequate tools that they weren't confident would stay controlled within the blood vessel architecture, go through the tissue and deal with the tissue and only the tissue and not touch the vessel wall at all. So after about 3 years of studying interventional cardiology, talking to physicians after physicians, begging them to see if they could open up those totally blocked arteries that other physicians had left alone, many of them said, no. I went to Japan, asked them to see if they would accept my father as a patient. They said, no, sorry, he has to come up from our own system. Now, I couldn't turn a patient from India into a Japanese patient. So this was looking rather desperate. But then when Pearl was sold to AstraZeneca, the word spread in Silicon Valley that here is somebody who knows something about how to build companies. And all of a sudden, entrepreneurs would come to me seeking either my advice or mentorship. Investors would come to me thinking that I had made the $1 billion by selling Pearl when the VCs had made the $1 billion. But one of those investors happened to be a dear friend of mine, Mr. Ram Reddy, who is in San Jose, who is an investor in many venture funds. He brought a brilliant physician to me. This physician wanted to be a surgeon, wanted to be an engineer, became a general surgeon, and then he came to the US and became a vascular interventionist who was just as frustrated with those devices that were inadequate for these blockages. So that physician, Dr. Malik Thatipelli, who is one of the founders of AngioSafe, came up with a device that made so much sense to me, that would stay within the plaque, not damage the vessel wall, and stay controlled through the blockage, that the three of us joined hands to launch AngioSafe in 2014-15 timeframe.
And coming up next, you're going to find out more about this device and the success that they have had with AngioSafe, including a 60 centimeter, you heard me, 60 centimeter long calcified occlusion in the leg artery. You're going to hear how they did it. That's next, right here on The Heart of Innovation. Don't go away. Now we're getting into the heart of it. I can see Marina and Heinz going, oh yeah, here we go. Here we go. Yeah, as Joshua said, you're a really great storyteller.
Well, thank you.
This is pretty incredible. Oh, Jesus. So we only have a 5-minute segment here. Holy crap, we're gonna have to have you back. Again, so it'll take us another 3 months to get you back. So in this next one, let's get to exactly the device and what did. So you never were able to get to cardiovascular with it yet, because you have to start in the legs, right?
No, we are both. We are working on heart and leg blockages both.
Have you done the heart blockages yet?
Yes, we have a device that is in clinical development for the heart blockages too. And it is showing great safety data. We have devices for blockages everywhere in the body. The one that we have is for above the knee blockages. There is one coming up for below the knee blockages, dedicated to below the knee, one coming up for the heart, and later on the veins and even the brain.
Do you have anyone that's over near, I can ask Bradley, but I'm curious because Marina has, I think Marina, it's an 100% blocked iliac artery and they can't get through it. And she doesn't want a big bypass. And so I'm wondering if if you've had success in the iliac with 100% blockages, true lumen, not subintimal.
Yes. Our current device.
Not Marina. Oh, Wanda. Where's Wanda? Sorry, that was Wanda that has it.
Oh, sure, Wanda. There are some great physicians who may be able to help you out. Our current device isn't indicated for aortoiliac regions. It's only indicated for femoropopliteal regions. But who knows which physician might wish to use the device which way, and may be able to revascularize even those arteries. But I think our science is giving physicians confidence to tackle disease in a variety of different ways.
Yeah, they just want to make sure. And this isn't something, so you might want to get into, so most devices, is yours guided by the wire? It kind of acts like the wire, because if the wire can't get through, that is a complete total occlusion. That is, you typically sends a person to amputation, right? Or a doctor may try going subintimal, trying to go around, stenting around. That's not going to last very long. But you would argue that your device, in a sense, is the wire, right? You just nose it on up to the blockage and start burrowing. Was that?
Yeah, that's one way to describe it. We are wire free.
Yeah.
One should not have to. The physicians really shouldn't have to push a wire. It's like pushing at the end of a rope from outside the body, hoping that the tip is going to stay controlled where they want it to be. It is a nightmare.
How
And
hard is it to get a doctor to not push? I just had this conversation with a doctor the other day, and he was saying that this other laser that was the wire that they would use, um, he was like, oh, it didn't work. He kept kinking and then it perforated. I'm like, well, because you likely pushed. Like, let the device do the work.
no. See, the thing is, if you can't control the tip of a long implement, a weak implement from outside the body, that tip can go anywhere if it runs into an obstruction. So physicians never perforate. They don't intend to. It's the device that does. Inadvertently, physicians just discover the perforation.
Mm-hmm.
Okay, after the fact, because
After the fact,
right? I mean, the core principle of medicine is first do no harm. Why would a physician want to perforate? They admit that they perforated, but really it's in the fact the device that was not controlled that perforated.
this is considered atherectomy. Heinz is asking. It is considered, right?
Our device, no.
30 seconds.
It's not considered atherectomy because you're removing the plaque.
No, we are not removing the plaque. We are removing the plaque as an obstruction without removing it from the body.
Oh, interesting.
This is again, Heinz, the picture behind you is the one I'm going to refer to. The plaques have properties of snowflakes.
Okay, we're going to get to that in a moment. So
they're compressible.
Vehicle killed a brigadier general, a captain, and another soldier.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
welcome back to the show. Dr. John Phillips is off today. We are interviewing a prolific entrepreneur who's gone from creating breakthrough asthma devices and is now creating a breakthrough, or has created a breakthrough vascular and cardiovascular device that burrows through the plaque in the arteries. 100% calcified blockages in the arteries. We have a very short time here. Sarvajna, before the break, you were getting into this new device, so tell us more about it.
Indeed. So when you look at total blockages in arteries, they develop over time. And the structure of those blockages is highly unpredictable. Physicians often find the structure of those blockages as it reveals itself as they start to do interventions with those blockages. Sometimes actually more often than not, and practically always, the front end of the blockages, the proximal end of the blockage, the cap, is harder than the body. And then throughout the body, the structure is highly variable. So to overcome this structural variability within a patient's blockage, inter-subject variability, patient to patient to patient disease variability. A patient who has diabetes may have a different structure of the blockage. Patient who is hyperlipidemic may have a different structure. Patient who has had lifelong smoking and has had inflammation could have a different structure of the blockage. These are highly variable targets for physicians to overcome. And to tackle this problem, the world of innovation came up with a variety of different tools, starting with wires of a variety of different kinds, numerous wires, microcatheters, and combination of those two in a variety of different algorithms. If this, then do that. If that, then try something else, and keep going through this. So this complexity of the tool and algorithms creates a situation where experience of a physician, practice and expertise of a physician becomes the primary predictor of success. And even then, the success is in a variety of different forms. When AngioSafe was conceived in 2014, leveraging the imagination of one physician who thought totally opposite to how the rest of the world of innovation thought, which is have a large catheter that is totally visible under standard usage and covers a large part of the blood vessel. So it would stay within the blood vessel. It would not inadvertently puncture the blood vessel wall, and keep it controlled within the blood vessel lumen with a centering mechanism, a mechanism that seeks the middle of the blood vessel more than the wall. And if it ever goes to the wall structure is unperturbed. Hence, we name the company AngioSafe. And this combination of a feature that's a large catheter, but with sharp forward direction features, blunt lateral features, and in between the sharp and the blunt features have slopes that would take the plaque that would be disrupted by the sharp features, compress that plaque locally against other plaque, the remaining plaque, without ever stretching the vessel wall. And that would then lead to a very controlled passage through the plaque while creating a channel without perturbing the vessel wall in ways in which traditional devices perturb. And that's what we have proven in the form of our lead device. It's called Centriva ATK endovascular revascularization catheter. Not crossing alone, it crosses and forms a channel, a blood flow channel, simultaneously, that the blood flow is restored in one pass without wires, without a family of devices. And that's the latest innovation. Behind it, we have innovation for below the knee arteries, for coronary arteries, and later on for veins and other occlusions in other parts of the body.
And coming up next, right here on the Heart of Innovation, we'll find out if this device is in the doctor's hands in your neck of the woods. That's next. Stay with us right here on the Heart of Innovation on KDOW. Don't go away. And I'd love for you to give a little bit of an analogy of exactly, and how long it takes, I mean, to get through the 60 centimeter blockage, because I would think that would take a while.
Yeah.
That takes a lot of patience. I mean, you can't even get a doctor to do a 2-minute balloon inflation. It's just absolutely crazy.
Yes.
So I'm just, and I remember with this laser that I had observed for so many years, I mean, they were quitting if it wasn't through in like 30 seconds. It was like, no, these are long calcified occlusions. This is going to take a while. It took a lifetime to build. Just take your time. Don't push. Let the device do the work.
Yes. Yeah. So a couple of things. Atherectomy officially in our code of federal regulations is defined as intraluminal artery stripper. It's designed to strip the arteries off of the plaques. And that energy is indiscriminately applied to the walls and to the plaques together. You can't control it. Physicians can't control it. Laser does a little bit better job than other atherectomies. So we chose not to focus on stripping the artery. We chose to work with the nature of the disease, which is naturally compressible plaques. Charles' daughter discovered back in 1962-63 accidentally, and this was in Oregon, that the plaques are compressible like snowflakes. You can take snowflakes, consolidate them, air space frees up. Plaques have the same property. We leverage it such that if you puncture the plaque and turn it around and compress it utilizing a forceful device, but without ever stretching the vessel wall, then you can keep the vessel wall safe while forming a channel. And this does not require us to shred the plaque and remove it from the body. We just compress it locally. And this gives a vessel safe, an angio safe passage. And this happens with soft plaques, hard plaques, calcium containing plaques, short plaques, long plaques. So time, your question, how long does it take? Time is all dependent on how perseverant the physician is against a given plaque. The beauty is here, they don't need to abandon the device after they run into an obstruction. The device has properties of being pushed harder than anything else they have pushed thus far. And stay safe, stay within the vessel architecture and go right through.
And so how is it classified for reimbursement?
We are working on reimbursement. Today,
Okay.
the current codes that have been launched this year, January 1st, the device falls under the category of the complex interventions. And within those codes is the language of all maneuver. So this device falls under that all maneuver definition. But we are
Is it
working
considered
on
a
it.
crosser?
No, it is officially an endovascular revascularization catheter. It is a procedure. It is not just a technology, it's actually a procedure which simultaneously goes through these occlusive plaques, complex plaques, and foreign aid channel that gives us blood flow all in one step, and physicians don't have to worry about using 4 different families of devices. So basically,
And do they
go ahead.
can they follow with, let's say, Spur, once Spur has the sirolimus, the drug coating on it, and then, or is this just followed by a drug coated balloon? Because right now Spur is not above the knee, it's just below the knee. But
Understood.
are you followed by a drug coated balloon or POB?
Physicians can choose any technique that they deem appropriate for that vessel that we have now opened up with blood flow. They
Now,
couldn't
I mean,
use they couldn't use any of these techniques unless we provided the channel.
the
So
long
they,
calcified occlusion is the Achilles heel. And one of the issues that we do have is the thigh is a bad area to stent. The knee, I don't even care with the supera. You're still
yes,
going to kink it if you sit down in a squatting position for too long, right?
indeed,
So are
indeed.
you finding that people are stenting after this, or are they able to tiptoe in, not cause a major healing response, no perforations or dissections, so no real need to stent?
I think this is my judgment. This is my feeling about the vessel wall health.
30
If
seconds.
if you can not have a foreign object and have just plain old balloon angioplasty,
Yeah.
maybe they will do drug coated ballooning and discharge.
Yeah. Okay. Yeah. It's amazing. So maybe you can, we'll have you just, 'cause we have 4 minutes, so it's really quick. I'd love to get to the 60 centimeter story, the analogy with the snowflake,
1220
and then how widespread you are right now.
Sure.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
As Dr. John Phillips always says, we're rounding third and wish we had a 2-hour show, but we have 4 minutes less, even less now if I keep talking. Want to get to Sarvajna Dwivedi, CEO of AngioSafe. Before the break, we were talking about your new device that can get through the toughest blockages, the Achilles heel for doctors, which is those long calcified occlusions right now, especially in the thigh. And you had a great success story, a 60 centimeter occlusion in the legs. Who got through it, and how was that even possible?
So long occlusions and calcified occlusions, even if they are short, they are among the most difficult ones today. There is a high failure rate in revascularizing those kind of occlusions. Our discovery is that of a device that has the full force range available for all of these occlusion types, provided the physicians persevere with the algorithm we recommend, where they don't need to change the device, they just need to continue to utilize its properties. If from multiple directions, it's a tri-directional device. They can use it from the opposite limb up and down. They can use it from the same limb downward, so they can come up from behind the knee popliteal artery upwards.
Retrograde, yeah.
Tri-directional device. This is the first device of its kind. This allows us to deliver full force to tackle these blockages. Sometimes the device will move slowly because it's facing a strong headwind of a very hard occlusion. And sometimes the device will go right through. It's the same device that can tackle all of these plaques. So we have had physicians are now in over a dozen countries use our device after its launch last year in September, October timeframe. We received CE mark in July and FDA 510K authorization, marketing authorization in September. Both jurisdictions as endovascular revascularization catheter. It's the first catheter of its kind that has been given this name. We restore blood flow. Our experience has ranged from short, hard blockages crossed rapidly to long blockages as long as 60 centimeters from physicians in Greece, in Italy, to now US, and the 60 centimeter experience is with Dr. Venkatesh Ramaiah in Phoenix, Arizona. But we have had Dr. Craig Walker, Dr. Pradeep Nair, Dr. Aaron Armstrong in the US, and beyond that, many other physicians use our device throughout the United States. Dr. Sudhir Mungi in OSF, Dr. Subhash Banerjee at Baylor Scott White. The list is growing right now. In the US, the device is available throughout the country. We have regional sales team that's covering all of the major territories in the US. Outside of the US, it's available through our distributors in almost 29 countries now, and we are going beyond. Now, what we leverage is the natural compressibility of plaques. Those are the properties of snowflakes. And this discovery was made by Dr. Charles Dotter back in 1960s, the father of interventional radiology in Oregon. Plaques are compressible just like snowflakes are. That's the core property we utilize without ever perturbing the vessel wall intentionally or accidentally. And that's AngioSafe's innovation. We look forward to helping patients worldwide with the innovation.
And thanks everyone for joining us. Thank you so much, Mr. Dwivedi. We really appreciate you joining us. And if you want to continue the conversation, go to youtube.com/the way to my heart. And we're going to continue this live right now on YouTube. So I know that a few people have a few questions. If you have a few more minutes, that was a really great wrap up, Sarvajna. We really appreciate it. I know that we have Douglas here and Wanda here and Thomas here and Don and Heinz. And we also have some folks on YouTube. If anyone has a couple more questions, we just want to keep them for a few minutes since it is on a Saturday. And we don't want to keep them too long here. So if you do have questions, make sure put them in chat or raise your hand really quick. I see Douglas coming to the computer. Douglas, go ahead and unmute. I know you have a question. Oh, I have to unmute you. There you go. I know it's, I'm so annoying, but I knew it was coming.
That fascinating, utterly fascinating. Now the snowflake idea, I kind of get that. Can you give us a little more of that and how your technique would actually like solve it, like melting a snowflake, I guess?
Yes.
We're pushing
Yeah. So imagine this. Imagine those trains that have a big snow plow in front of them. And those trains go through a pile of snow, throwing the snow aside. And then they create a path. Now imagine if there was a tunnel full of snow, blocked with snow. And now that same train goes through. The snow plow will now plow through the snow and compress that snow against the wall of the tunnel without stretching the wall of the tunnel outwards. Just the snow becomes solid. That's what we do with the plaque inside the walls of the arteries with our device. But we don't use a plowing mechanism because plowing allows you to potentially carry a plug of snow forward. And you don't want that to happen inside the arteries. So what we do is we take a little loop that is very, very sharp. And that is mounted on a torpedo-shaped steel tip. That's bigger than the loop. And then this is controlled by a flexible nickel titanium centering mechanism, which is flat against the wall but sharp in the forward direction. And then we rotate this loop and the tip such that the front edge of the loop is scraping a layer of the plaque sideways. And then the torpedo-shaped tip takes the force of the device and compresses that side displaced plaque against other plaque. And that then creates no debris carried forward. We are just clearing up the debris, immediately compressing it, and we do so. And it actually, the device does a really consistent job in calcium. Okay, with the softer plaques, even if we compress them, they might have a tendency to come back a little bit. Calcium, once we do the job, it stays compressed. So this is what we have observed in our science, in our clinical work, and this is the kind of evidence that gave both European and US authorities the confidence of giving us the name endovascular revascularization catheter. What does that mean? Revascularization is a combination of two terms. One, recanalization, channel formation, canal, channel formation, and reperfusion, which is providing sufficient blood flow through that channel that the previously blood deprived organ now has sufficient blood reaching it. So combination of channel formation and reperfusion, recanalization plus reperfusion gives revascularization name. And we achieve it by taking the plaque a layer at a time, side displacing it, compressing it, and staying within the architecture of the vessel wall without perturbing the architecture of the remaining architecture of the vessel wall.
And
One
we're
more
going
quick
to
one.
go ahead.
Can I?
Go ahead.
So we have people in our group who have been told they're at the end. There's no more procedures that can be done. They're just at the end. How is this? Can this technology affect those because you're able to do things we couldn't do before?
Sure. I understand, Douglas. I know how the thinking is today in the physicians, in the physician community, and here is the reason why. The puncture force, if you took the blockages from human limbs, so this is what a team led by a brilliant physician, young physician named Dr. Trisha Roy did in Toronto, in Canada back in 2015-16. They took human amputated limbs, they took the blockages out of them, they measured the structure, they assessed the structure of those blockages by MRI and histopathology, which is microscopic examination. And then they also took a wire to measure the puncture force of these plaques. And they found that soft and hard plaques could take up to 300 gram of puncture force. And calcium containing plaques, they were unable to puncture in that attempt. So today, there is no device that has this full force range to puncture all of these plaques. Now, many of the aged blockages probably end up having so much calcium in them, so much hard plaque in them, and such long plaques that physicians feel that they just don't have a device that can go right through it without them damaging the vessel wall, except our device. We have determined the force that we deliver with our endovascular revascularization catheter to the plaque. That's in the range of 600 grams or more, up to a kilogram, which means, and we do so only in the forward direction, not accidentally laterally towards the wall. So physicians now have a more powerful tool than they ever did, that they can push harder than anything that they could push before, and attempt to go through these, shall we say, last resort situations. So we have had many physicians who have had prior failed attempts, and I'm talking US and Europe combined, prior failed attempts, that patient that they had referred to for bypass surgery. And those physicians brought those patients to use our device, and we were able to puncture those plaques. Those physicians who persevered with our device in those plaques, they have been able to restore blood flow even for those patients. In some of those cases, the physicians found that they were taking just too long, even though we were in the plaque. And maybe they will bring that patient back after having gone through 8 or 10 centimeters through that to finish the rest of the plaque and restore blood flow.
So it's amazing what I hear you saying is that there are going to be, we have another option going forward, that even if you've had a bypass and the bypass fails, that this is a device that's becoming more widespread that might allow some of those doctors to be able to now recanalize the native vessel and leave the bypass blocked, because it's just, and I think Marina is smiling because it's just new technology like this coming online every day gives you hope that there is another option, and there is another option, and there is another option, that we're slowly getting out. And for example, with Thomas, with Dr. Nair and Dr. Walker, they just started using this, and they're using it more and more, that he might be a candidate going forward for it once they recognize that maybe this could be used, like Venki Ramaya out of Arizona, on a really long 60 centimeter occlusion, right?
Yes.
And so go ahead.
Yes, I think the way you characterized it in the opening part of that remark is correct. There is an option. There might be a way. What happens is when a patient has gone through a bypass and the native artery has remained blocked, the native blockages become harder and harder over time. They are harder to go through. The interesting thing is we have been able to tackle even those native blockages.
Yeah.
Okay. Yeah. But some preliminary experience and in various different settings. So I think these are early days of our launch. We only have gotten the device in the hands of a few centers in the United States. We wish to bring it to every single center. I don't want a single patient to be sent home like my father was sent with just a medical prescription. I do not want a single family to feel that desperation that I felt. That's the core motivation behind AngioSafe. So I think physicians, once they get a hang of this device, this new way of tackling plaques, they will be able to help the patients in ways that they haven't yet done before. Maybe they will try to go through the bypass graft itself, if they can figure out where the anastomosis are.
Yeah.
Or maybe they can go through the native artery, or do a combination of the two. In our very early experience in 2017, first ever patient we tackled was an 86-year-old female, 14 centimeter severe calcified blockage in her left limb with 2 toes ready for amputation.
Yeah.
Dr. Ramaya went through that 14 centimeter long blockage. I'm talking October 17, 2017. In a matter of 10 minutes, 6 months later, that wound, those toes had healed. The limb looked pink. She could walk pain-free. Imagine amputation, and imagine now that. That's the experience I'd like every single patient to have. And this goes back to 1960. 64 rather, I think January 1964 is when Dr. Charles Daughter, when he first discovered that the plaques are compressible, he started to do these interventions purposefully. Vascular surgeons didn't like it, okay? But there was a young lady, 80-plus-year-old lady named Laura Shaw. She refused surgery. Vascular surgeons wanted her to have surgery. She had toes that were gangrenous, and she had a blockage that they wanted to do bypass surgery in. She refused. So out of desperation, the surgeon referred her to Dr. Daughter, And he opened up that blockage just by doing intervention, restored the blood flow, and she did just fine. From that patient to today's patients, to our 86-year-old patient, it took almost 50 plus years, 60 years. Innovation is not that easy. Okay?
No. And it just takes time. We're just on the cusp. And the thing that everyone has to be patient. And I'm curious because we are launching padtrials.org. And I assume that as you move into BTK and cardiovascular, that you do have a study or two going on right now through the FDA for those.
Well, with the above the knee blockage device, this is officially femoropopliteal device.
Right.
It's already launched. It's available. So
Right.
through you, patients, if they wish to, they can reach out to the doctors. We are making Dr. Walker Center, CIS, as one of the centers of excellence. Dr. Ramaiah is always there. We've got Baylor, we've got OSF in Peoria, Illinois. We've got a few centers.
And we do have a list of your reps across the U.S. so they can call our Leg Saver hotline 1-833-PAD-LEGS. And if you're interested in a doctor with this technology and to be assessed for it, you can definitely call our hotline and we can help to navigate you to one of those doctors so that you can have a productive conversation with them and see if this is something that might be right for your presentation of disease. And we're always happy to help with that. I just didn't know if you had additional studies that you're working on that would be especially for below the knee going forward.
Right. There is a below the knee study about to be conceived and launched. It's a pivotal trial. Okay. So that would be a controlled clinical experiment to assess the mechanism of our action. So it may not be a treatment oriented, it will be more of a mechanism of action, proof of concept, pivotal trial, about to start sometime later this year. A coronary trial is about to start later this year. And we probably will do other studies just with our currently launched device. A registry trial we might be doing with Dr. Banerjee at Baylor Scott White in Dallas. So stay tuned. There is a lot of action coming up. We are committed to transforming the landscape of complex occlusion disease everywhere in the body. Now, it took me 6 years to find a physician who would eventually open up my father's blockages. 6 years. How many families have that perseverance? Now, after that, my father lasted another 5.5 years. We lost him to brain hemorrhages. His heart was still going strong. Nature's remedy, the blood flow, helps in unprecedented ways. So I think all of your patient base with above the knee blockages, I think we have a real answer to some of their disease, hopefully all of their disease.
Yeah, I'm just wondering how many
blockages.
I'm just wondering, with this now in doctors' hands, how many fempop bypasses could be avoided. We have someone that just posted in the group that her doctor wants to do a fempop bypass. And I'm thinking, well, they could always use the detour and they can use the PTAB, the minimally invasive bypass. But why not try something like this first to see if you can get through in the native vessel? It's always important to make sure to try to get through the native vessel first.
Yeah. And please request the doctor to consider Centriva ATK, our device for above the knee blockages. And if your physician is interested, we can figure out a way of getting a device or two to them.
So they can try it. It's always worth trying. I don't know a doctor that wouldn't actually try something. I don't know. Have you faced resistance or any limitations or folks arguing for their own limitations and not wanting to try it? Or
no, physicians,
they're all willing.
Our concept of keeping vessel walls safe is consistent with their Hippocratic oath, which is first, do no harm. Always try to help the patient. So the concept is resonating with the physicians, but it does take time. There are 3 types of psyches, those who are willing to go for something new right up front. Okay, when Steve Jobs launched iPhone, not everybody bought it in year one. Some waited. Okay, uh, but then there are physicians and there are other physicians who would want to see others try it, and then even others are the ones who would wait for it to become adopted in day-to-day practice. But for a specific patient in your audience, you can't wait for that thing to happen. So have your physician contact us. We have a number on our website, or through Kym or through our sales team. We can figure out a way of getting a device to that physician to help you out.
Never hurts to try. And Don wonders if the product
Yes.
is approved for the Netherlands.
Yes, it's in the Netherlands through a distributor. It's available there. You can contact our sales team, and they can put you in touch with the distributor. Dr. Boziers, Bosiers in the Netherlands, tried our device first. I mean, he tried the device off-label first in a stent blockage.
Yeah.
Now, we are not supposed to promote. I'm not promoting it. I'm simply letting you know that Dr. Boziers tried it. He was so confident about the properties of the device that he put it in an off-label situation. Now, there are
the
some
stent blockage was in the thigh, right?
Yes, yes. Now, there are some questions in the comment. How did the Japanese take the innovation? We have yet to reach Japan, but we are speaking with potential partners in Japan to try to bring this device over there. We have spoken to Japanese physicians who would appreciate this very much because Japanese culturally don't like surgery. So this is consistent with what they started, which is wire-based innovation. Okay, and wire-based intervention. We just want to help them along the same themes that they have been on, which is wire-based. Okay. Now, Douglas is asking, get through an axillary bypass on aorta bypass.
Yeah, he has
blocked.
an axillary bifemoral bypass that goes from the axillary all the way down, and then it splits off in a fem-fem, and that's completely blocked. He also has an aorto bifemoral bypass as well that, so the axillary is completely blocked. It's just of no use. Then you have the aorto bifem, and I think one of the grafts just became blocked, and they have to go back in.
Okay. You see, of course, our device is not indicated for these things. If your physician takes a look at the properties of the device and wishes to use it to try to help out, it's a choice that a physician can make. We just can't officially say it will work because our label is limited to femoropopliteal arteries.
And we have Heinz. Heinz had a question and a couple things to say. Heinz, go ahead. Oh, I know. I have the power and I need to stop that. Here we go.
Thanks for all your information. So I'm happy to hear my doctor is one of the doctors you mentioned earlier that can do this. And you did just touch on that about someone, I believe, in the Netherlands. What about the stents? I mean, if you have stents, have people already or doctors already tried to go through the stents with this device, or is it just one-off that has done it?
I have to be careful so it doesn't come across as promotional off-label. But physicians have commonly asked this question, that how do we feel about our device's ability to go through stents? And this is the answer I provide. It's all steeped in science. When stents get blocked, the tissue that is occluding the stent is of a different kind than the native total blockages are. It's more like hyperplasia. It's more like a tissue, more like a muscular, a different kind of structure. So for that kind of a tissue, the device has the mechanical properties to puncture it and conduct an intervention. Now, physicians who understand that part, we have had cases And we hope that those physicians would actually publish it to inform the clinical community that they have been able to go through stents and revascularize those patients.
Okay.
So I believe there is real hope here, but since our label excludes in stent restenosis, I cannot officially say it will work. Physicians may be able to use it and may be able to succeed. I would encourage those physicians to get some experience with the native disease first before they take on a higher risk scenario of a stent.
Yeah, Heinz, it's typical for doctors to use a lot of these devices off-label, and it's still following their Hippocratic oath that do no harm, right? They have to be confident it's not going to do harm, that the benefits outweigh any of the risks, especially. But there are quite a few doctors out there that are using a lot of these devices. For example, the coronary stent. A lot of doctors are now using coronary stents because they're tiny and they're using them in below the knee vessels. They've been using them there actually for a very long time. It's becoming less common because you have the new Spur retractable stent. You also have Abbott's Esprit, which both are designed for below the knee vessels. The Esprit is a dissolvable stent. They're now looking at, some possible drug-coated balloons that might be safe down there. So there's a lot of technologies there, but as I said, it started with a lot of the doctors using the coronary stents below the knee. I was just aware of a situation with a new lithotripsy balloon from Boston Scientific called Seismic. And a doctor was getting trained by a clinical specialist for Boston Scientific. And the doctor was like, oh, I'm going to use it instead. This would be perfect. I have no other option. And the clinical Spanish specialist was like, oh my God, wait, it's off label. He says, well, you could leave the room because I really think this is safe. I really think it's going to work. And of course it worked. And the patient had blood flow restored using this particular device. So as Sarvajna was just saying, that there are doctors that are starting to get really comfortable with it and seeing the potential for in-stent restenosis. But right now, the standard is using a laser and drug-coated balloon to get through in-stent restenosis when they can. But it's nice if they can't get through it with the laser, and then this could be an option. So thank you, Sarvajna. I really appreciate you being here, for staying after. This is amazing. We would love for you to come back. We'd love to bring Venki. I talked to Venki Ramaya from Arizona about bringing his patient, who was the 60-centimeter patient, on at some point. So hopefully we will. Hopefully we'll get a few more doctors. Maybe Dr. Nair, Dr. Walker will come on. Maybe your doctor from the Netherlands. We could get on with a patient so we could learn more about the success stories. But for everyone watching, just remember, always check with your own doctor. These, testimonials, it might not be right for your presentation of disease. You might not have the same outcome. We just don't know. There are so many variables when it comes to treating peripheral artery disease, but it's always worth the conversation. This content is for informational and educational purposes only. Do check with your own healthcare provider before acting on any of the advice offered here. Thanks everyone for joining us.
Excellent. Thank you so much.
And don't forget to like this video and subscribe to our channel.